So I was actually really excited when I came across this article from the Community Mental Health Journal 2016 because the authors and the researchers were uh, part of our friend David Satcher's group at the Morehouse School of Medicine. So this this piece of research in the article subsequently is a partnership between the uh, the Morehouse School of Medicine and specifically David Satcher's group within the Morehouse School of Medicine, in partnership with the Grady Health System and the Georgia um, Health System, so the state of Georgia Department of Health. So, so I'm really excited to go over to include this article here. So just quickly on this slide, again, a lot of these things that you've already heard Dr. Satcher talk about and different clips with him. The one thing I just want to point out here is that when I go back and I've read about the policies associated with deinstitutionalization, and this is kind of just for what it's worth from a historical perspective, it was kind of like it was done one halfway and out of order. So in other words, the whole idea, the way I understand from what I've read about it, is that there was to be a community, kind of a network of federally funded community mental health centers across the country. And then there would be deinstitutionalization, one to save money and to allow people more self-determination to live in the community and get their treatment where they live instead of living in an institution. So, but what ended up happening was the presumably cheaper part was done first, the deinstitutionalization, putting people out in the street and shutting facilities down, ahead of setting up a robust community, a network of federally funded community mental health centers. The other thing that happened, and I guess it's hard to say how much this directly impacted from what I read, but it would be hard to believe that what the other event of 1963, which was the assassination and death of President Kennedy, um, had some bearing on this. Certainly, a distraction, much like 9/11 in some ways, a distraction from everything, understandably, but a distraction nonetheless from everything policy-wise that was happening that period of time. So, would we have had a more successful output of this had Kennedy not been assassinated? Um, I don't know. But it's an interesting thing that comes up when I read about it. So I just wanted to share that piece of it with you. So here's just the actual list of partners involved in the study and in the article. And sorry, for those of you, I meant to add this in the last soundbite. For those of you not familiar with this area of the country, this is all kind of the Atlanta metro area. So I just wanted to point that out. So when I first pulled this article for this course, for this particular lecture, I actually did try to recreate this chart in a slide form, and it just tried a couple of different times. This wasn't happening, and it was making more of a mess than it would have been helpful to you. So I just took a picture from the journal itself. But it's really just a very sound approach of being able to just, instead of, oh, there's that psych patient or there's that intoxicated person again, is to just say, okay, are they medically stable? Meaning, are there physiological problems that must be addressed right away? Um, then let's treat them in a kind of quote unquote traditional emergency setting. Um, if they are, if there's no acute physiological issue that needs immediate attention, but they are, using their words, psychiatrically unstable. Presumably, in the context of this article, that means someone who is not safe outside of a facility, or like a hospital, or at least safe outside of direct supervision because of psychosis or suicidality, or homicidal intent, violent intent, um, or someone who may need having a reaction to medication, may need some abrupt medication changes that require a kind of heavier, more intensive pharmacological supervision. Then that would also fall into there. And then those who didn't have an acute physiological problem, that weren't unsafe, and by suicidality or uh, behavior or psychosis, and didn't have any acute pharmacological issues, then we get them into outpatient and community care. And so instead of kind of what we often see in emergency rooms, or at least what I saw in my travels in the emergency room, where it's like, there they are, that we can just kind of approach it in a very methodical way: physiological stability, psychiatric stability, and based on that, which direction to send them. And of course, you have to have, and this is part of the point of the study, you got to have the infrastructure there, and you got to have the services, particularly outpatient services, available in a timely fashion to make this model work. That is something that was certainly missing, well, not missing, but not there 100% of the time when I was working in the emergency room. And I'm well aware that that's and as a provider of outpatient services myself, uh, these days I'm aware that that is not always available in a timely fashion in an emergency department situation.
So here's a little bit just about the background of Grady Hospital. It's a very old hospital, level 1 trauma center, uh, a place that's certainly going to see, and in a metro area in or near Atlanta, and certainly includes some of the most underserved in that area, like any city hospital. So here are some of the goals of the program. A lot of it kind of the triple aim type of stuff that we've been talking about. So the authors very smartly gave the service its own name, and kind of its own brand. This psychiatric fast track service. So people in the emergency room, in the staff, will it has a sense of identity about itself. I also wanted to point out that the psychiatric fast service staff, is comprised of social workers. They work mostly daytime hours, which of course is not someone who worked nights and weekends for many years in the emergency room. I can tell you those can be the most busy times. I guess it wouldn't be a surprise to you guys. They also had a psychiatrist available for phone consultation, and part of what the social work assessor's jobs were in the psychiatric fast service was to also enter a certain amount of data into a database with each assessment that they did, to help track how they were, the volume, and a lot of the particulars about the demographic particulars about the folks, and health particulars about the folks that they were seeing, so that they could track the work that they were doing. And then the other thing, and this is obviously critically important, is that they coordinated with an after-hour crisis intervention service, and then they also worked closely with outpatient services. Again, the idea being that providing this type of care where we're trying to minimize the amount of people who end up unnecessarily hospitalized and get them the most appropriate safe level of care is dependent on is only as good as the availability of those services, and you have to track that, right? So we need to, if we're not paying attention to the timeliness of that follow-up and the extent to which people are following up, and if they're not trying to understand why they're not following up on those outpatient services, either if it's discharged from the hospital or an attempt to get them to community care out of the ER, that's a critical part of any project like this. So part of the advantage of having a teaching school like Morehouse involved in this project is that these same social workers are also able to provide educational services. So not only are they providing this fast track service, but they're providing behavioral health training, and particularly emergency psychiatric training, to the non-behavioral health specialty physicians and psych residents. So, regardless of the output, providing of the study itself, they get the added value of that additional training, as we've seen in some of our other, that we've maybe discussed a little bit in some of our other material, that physicians still don't, or medical school students still don't get a whole lot of behavioral health training, unless they're specifically specializing in that direction. And we know that not many are necessarily specializing in behavioral health and psychiatry or addictionology. Anyway, the authors also smartly identified some measurable goals: reduction of ER wait time, reduction in use of restraints. I put presumably physical, but that could also be potentially the reduction of use of injections like Haldol, for instance, and also compliance, better documentation compliance with involuntary holds, and increasing, kind of protecting the facility legally, and more importantly, protecting the patients to make sure that when we are holding someone against their will, that we're doing it and with sound legal and clinical reasoning, and we're following the process in an ethical manner.
So after a little over a year, the researchers found some notable findings. One, the overall length of stay in the emergency room was decreased by 9% in terms of time, and the decrease in use of restraints. Restraints were reduced, or the instance of restraints were reduced by 14%, and that they were able to, um, with some statistical analysis, find that there was a correlation between the decrease in the use of restraints. Sorry, I think that's a typo there. A decrease in the use of the restraints was correlated to an overall reduction in length of stay in the emergency room, which would make sense. And then they added some economic analysis to this. And again, all the things we talk about, right? And all the things that, for all the reasons that Dr. Satcher talked about in the video from earlier in the course, that when you start to add all these things together, when you're getting proper care, more effective behavioral health care to people in the emergency room, and especially better follow-up, you start to really begin to reduce not just healthcare costs, but costs to the infrastructure costs to your community, right? Criminal justice, law enforcement, in addition to healthcare. So anyway, so after a little over a year, they were able to show some measurable impact